Good afternoon. Thank you. Good afternoon and welcome, everyone. We're really pleased that you're here. My name is Hal Stern. I'm the Provost and Executive Vice Chancellor at UC Irvine. When we have people from outside the university here, I like to describe what my job is, and I find it's helpful for the people on campus too, because they have no idea what I do either. The Provost is the Chief Academic Officer, and the Executive Vice Chancellor is the Chief Operating Officer for the university. In the former capacity, I have the opportunity to work with the deans of our various academic schools, and today, especially the School of Population and Public Health, the Wen School of Population and Public Health, and Dean Bernadette Bodnavala. So she invited me to say a few words, but when I saw the program, I realized it should be very few words because there's an actually truly outstanding panel who's going to really talk to us about a critical issue. So as you all know, universities in their entirety are facing a really challenging environment with a lot of questions about our value. We get critiqued from all sides on costs, on some sides for the culture that we have on campus and the like. But I will say that one discipline that can relate to the general anxiety that the university is feeling is public health, because that is a community that has also been facing increasing levels of attack and vitriol and disbelief, and it's really to the harm of all of us that is happening. The work that's happened in public health are many of the actually most important things that have happened to extend our lifespan and our health span are public health developments first and foremost. And so the fact that people are losing confidence, or that there are people attempting to cause a loss of confidence in public health, is something that should be of great concern to all of us. And for that reason, I'm going to turn it over to Bernadette. I'm really looking forward to, I think we're all looking forward to the work that the panel can do. I regret that I can only stay for a few minutes, but thank you all for being here. We're really grateful.
Thank you, Provost Stern, for the generous introduction, and good afternoon. It's really, really exciting to see all of you here, and especially meaningful to be introduced in a room filled with leaders and partners and colleagues who care deeply about the future of public health. I want to acknowledge something else that makes today very special, and that is that even we at UCI Wen School of Population and Public Health are very new. A number of our panelists, Brad, Michael, and Deena, who you'll hear from later, are actually UCI alumni, and they trained right here in this community, and now they are out there shaping public health across California and the country. It's really a reminder that the work we do and the students we train truly pay it forward. Before I begin with a briefing on the four major forces shaping the health of our nation, I want to frame this moment plainly. We are living through one of the most consequential shifts in public health science and governance in modern history. The decisions now at every level will shape the health and well-being of our communities for generations. Sadly, across the country, public health and science are under direct attack. The current administration's policies, budgets, regulatory and ideological, are converging into a perfect storm. We often talk about threats to public health in the abstract, mostly when we're talking to students. But today, the threats are very real, very specific, and very targeted. So today, and I promise you, I will do a brief, 10 minutes. I'm going to move big picture, macro challenges to the direct personal consequences of the state of public health, children, families, and communities. Federal actions shape our collective safety and well-being. Federal funding accounts for roughly half of all state and local public health budgets, which means every federal cut translates immediately to reduced services, fewer staff, and less community capacity. The federal fiscal year 2026 budget proposal includes a 26% cut to Health and Human Services, following an earlier 10 million cut to women's health that fortunately was reversed and restored some of the funding, but ensuring chaos still remains. And NIH fiscal year 2026 base funding is expected to be slashed by about 18 billion, about 43%, threatening research across chronic disease, maternal health, health equity, and reproductive health. One really important result is that tragically gender science and global health research are being left behind. And it's not just a budget issue. It's an erosion of our ability to produce evidence-based science, to protect families, and to respond to emerging health threats. Entire programs like the Teen Pregnancy Prevention Program and maternal health initiatives face elimination. Staff overseeing the Title V maternal and child health programs, the National Maternal Mental Health Hotline, and even the National Fertility Surveillance System have reportedly been laid off, fired. When we lose these programs, we lose lifelines for millions. And these aren't isolated cuts. They're part of an even larger retreat from the collection of a rigorous evidence base. At the very same time maternal and family health programs are being weakened, the country is also turning from science-driven climate safeguards, regulations designed to prevent catastrophic wildfires, prevent frontline communities, and limit greenhouse gas emissions are being rolled back. We're watching the long-term impacts in real time, from Lahaina to Puerto Rico. Under Executive Order 14192, the federal government has adopted a sweeping 10-to-1 deregulation rule. This means that for every one new regulation a federal agency wants to put in place, even if it's meant to protect clean air, drinking water, worker safety, or disease preparedness, the agency must first eliminate 10 regulations. This policy creates an almost impossible hurdle for agencies trying to respond to new health threats or emerging scientific evidence. The result isn't just deregulation, it's dysregulation. Instead of updating old rules to keep communities safe, agencies are pressured to strip protections away. This leaves the public, our communities, increasingly vulnerable to environmental hazards like extreme heat, wildfires, pollution, unsafe workplaces, simply because the safeguards needed to address these risks are too costly or too time-consuming to replace under the 10-to-1 rule. But weakening the rules that protect people from environmental harm is only one side of the story. The internal capacity of our public health agencies, the people, the systems, the infrastructure are being disrupted. This past year, we have witnessed the federal government's sweeping attempt to reorganize and consolidate key health agencies. On paper, this is being described as an effort to streamline bureaucracy. In practice, it has created chaos, and the courts are now stepping in. Earlier this year, a federal judge in Rhode Island blocked the Department of Health and Human Services from carrying out mass layoffs and restructuring several of its sub-agencies, finding that the administration has provided no rational basis for a plan that could have devastating consequences for the country. In her ruling, Judge DuBose detailed the real-world damage already unfolding. Critical public health services have been interrupted. Databases have been taken offline. And when databases are taken offline, the data doesn't exist anymore. And if somebody asks us for, well, what's the evidence? And the data doesn't exist, the evidence is gone. Grant funding has been thrown into chaos. Technical assistance training and consultation services have been curtailed. And as the judge noted, these are not unsubstantiated fears. These are disruptions happening right now. Ongoing research, maternal health programs, disease surveillance, and community-facing work that people depend on. Despite the ruling, an HHS spokesperson responded that the administration strongly disagreed with the decision and would continue to stand by its plan to refocus a sprawling bureaucracy. Hey, we understand, is the provost still here? We're all engaged in budget reconciliation. But the problem here is that refocusing is in the health arena, and it strips the ability to respond to emergencies and places scientific decision-making in a vacuum where politically appointed leaders, not career scientists, and my dean colleagues and I were just speaking a few minutes ago about deans of public health in sort of South Central, I guess. You can figure out the states, have been replaced by political appointees, have been moved out of their leadership positions. And so these choices affect everything from vaccine distribution to wildfire smoke protection. This isn't streamlining. It's destabilizing the very infrastructure we rely on to keep communities safe and healthy and happy. And if we can't protect the infrastructure, we cannot protect the science or the process of providing an evidence base. The next major area of concern is the growing set of barriers that threaten our ability to generate evidence, research, and innovate for our future. We are not only seeing new research blocked, current data destroyed, halting ongoing studies midstream. This has never happened before at this scale. As for future research, the NIH is making a major change to how it decides which research projects to fund. It's like the work and evidence never existed. For many years, NIH used a clear cutoff score, many of you know this, called a pay line, to determine which grant applications were strong enough to receive funding. Now, NIH is getting rid of those cutoffs. Instead of relying mostly on a score, all 27 NIH institutes will weigh additional factors, like their own research priorities, whether an applicant is early in the career, how much funding they already have, and even where they're located in the country. I think California, we have to hold strong. This shift could open the door to political influence, and that's the problem. Without clear score-based cutoffs, we fear that funding decisions could be shaped more by the preferences of political appointees, especially currently, rather than by scientific experts reviewing the research. This threatens progress in chronic disease, community-based research, and studies of vulnerable populations. And even the pipeline is being squeezed. Public health degrees have been reclassified in ways that make graduate students ineligible for certain professional level federal loan limits, restricting to enter this most noble field. And the same has happened for nursing, not considered professional fields. And I have to say, as a woman in health leadership, and maybe I'm wrong, is it a coincidence that the two fields under the greatest pressure, professional or not professional, are dominated by women? I hope I'm wrong. When the scientific backbone weakens, the stay in research labs. They show up in clinics, in schools, and in the lives of families. And that brings us to the third area, how these funding decisions are shaping people's everyday access to health care and health. At the individual level, the federal rhetoric has fueled vaccine hesitancy and paved the way for state-level executive orders eliminating school vaccine requirements. However, infectious diseases do not respect boundaries like districts or countries or counties or states. These decisions put regions at risk for outbreaks of preventable life-threatening illness. And when we cannot target interventions to specific populations because surveillance systems are weakened or data sets deleted, health disparities widen. We know that. And chronic diseases grow. We're also seeing pushes for Medicaid work requirements, which threaten to increase the uninsured rate from 7% to 11% in some projections. Even here in California, we're not immune. Changes in state budgets risk restructuring coverage for undocumented residents, though advocacy groups are fighting the hard fight to protect the most vulnerable. So we're seeing the impacts at every level, from environmental protections to scientific capacity to individual care. But despite everything I've just outlined, I actually remain optimistic. And I do it because 5 years ago today, my granddaughter was born in the middle of COVID, pre-vaccine, during those times when even the spouse wasn't allowed into the hospital. It was a time of chaos. We, my husband and I, hazmated ourselves to get on a plane to DC. We quarantined for 14 days. We did 2 tests from Costco, and we finally met our new wonderful granddaughter. But you know what? Thinking about those times, public health did take control. And we've learned so much and still do each day. And we saved a lot of lives. It's controversial, but we saved a lot of lives. And we proved in public health that we are resilient. So yes, I do remain optimistic because I know what this room and this panel represent. While current threats and like past threats are real, so too are opportunities for great leadership. All of this raises the question, who can the public trust? Confidence in federal institutions, especially the CDC, has fallen sharply. But that means opportunities for schools and programs of public health to carry that weight. We are among the most credible, community-embedded institutions left, and certainly here in California. As schools and programs of public health, we can model transparency, evidence-based communication, and community partnership. We are really fortunate to be in California, where the state is stepping up every day, every hour to fill gaps left by federal withdrawal, modernizing mental health systems and expanding care under Prop 1, protecting public health infrastructure, even as national funding waivers and preserving climate safeguards whenever possible. And all of the West Coast is stepping up. California, Oregon, and Washington have launched the West Coast Health Alliance to uphold scientific integrity under federal retreat. We can talk about that in the panel. It's not perfect, but here in California and in the West Coast, we are moving in the direction of health for all, not away from it. California is missioned to lead the training in the next generation, for the next generation. So we must contribute to train, build, and expand a workforce that meets rising needs, one that understands disparities, one that can work across political divides, one that can serve communities who have been sidelined by the federal landscape. Everything from healthy lifestyle to climate protections, to vaccine requirements. But that means, again, we have the opportunity to articulate, all of us, your mandate, our mandate, the value of public health, the economic case for women's health, for example, and the essential role of prevention through training, research, and service. We can keep the public health science alive. When federal agencies are stalled or reorganized into inaction, academic institutions must step in to innovate, partner, and fill gaps with the community, with foundations, with private industry. This must be our moment. Way to explore these opportunities than by hearing from a panel of dynamic leaders who are shaping every day the future of public health. Many of us have been working together since the start of the pandemic and have been continuously working together to improve health across the state. So let the fun begin. We've got the CNN round. It's election night at UCI Wendt School of Public Health. And I am honored to introduce my fellow deans and program directors of public health across the University of California. Brad Pollock is the program director at UC Davis. Brad, raise your hand. Cheryl Anderson, San Diego Herbert Wertheim School of Public Health and Human Longevity Science. Ron Brookmeyer is the dean of UCLA Field of Health. Michael Liu is the dean School of Public Health, and Mark Wolfson is the program director at UC Riverside. And last, but certainly not least, our panel will be moderated by Deena McRae, the Associate Vice President of Academic Health Sciences, University of California, Office of the President. Thank you.
For inviting me to be part of this amazing panel. And thank you for your inspiring words. Your energy, your passion, your commitment to the mission embodies exactly what energizes people to be proud of being part of the University of California. I'm not only grateful to be in the state of California, but very grateful to be part of University of California, which remains true to its values and mission, which we're going to talk about more today. So it is an honor to be surrounded by these public health experts and leaders. In this challenging, tumultuous environment, you have been tackling challenges head on. And I was hoping to give each of you an opportunity to talk about how your institution is similarly, but yet also sometimes uniquely leading the way in public health. So I'm going to jump around the table. So you're going to have to pay attention because you might be called on next. I'm going to start to my right though. Brad Pollock from UC Davis. So my question for you, how has UC Davis been leveraging California's uniquely forward-thinking environment to strengthen your training and research priorities?
That's a loaded question. First, I want to start by thanking Bernadette for inviting us here. It's great. This is a thrill for all of us to be in each other's presence. Secondly, I want to say it's a thrill to be back here in Irvine because I graduated as an undergraduate here in 1979. And who would have thought that this wasn't the science lecture hall? In terms of UC Davis, so we are the second oldest campus in the University of California system. The campus was established as the ag extension of the University of California that was located in Berkeley. And we are one of the newer public health programs. Our public health program started about 20 years ago or so, and we've been accredited, I think, for the last 15 or 16 years. We're in a unique situation. We are in a school of medicine. We have a department of public health sciences, so we're organized a little bit differently. We have 47 full-time faculty in the department. We offer PhD degrees, one in public health sciences, epidemiology, and biostatistics, and a master's of public health as well. Interestingly enough, we are located in our Sacramento office where the medical center is 10 minutes from the California Department of Public Health. And that hasn't been lost on us. So we are very engaged with CDPH and working with them. And many of the leaders in CDPH have faculty appointments with us. And so it's been interesting. And I think one of the unique aspects of what we've done is to really think about discovery science, the academic part of public health, and the application in public health practice, and doing this in a very, very fast way, and doing it in a very quick way and in a way that's very synergistic. And we have people that really cover that spectrum from practice to research and academics in a very transparent way. We also are dealing with unique problems in Northern California. I was going to say the wildfires, it's a big issue for us. That was until we had the Palisades and the Eaton fires in Los Angeles. It's a problem for the whole Western United States. But we have some specific healthcare needs. The other issue about our population in Northern California, most of you think that Sacramento is up there somewhere with San Francisco in Northern California, right? We are actually quite far north of the Bay Area. And in fact, we are in the geographic center of California. If you look at the map, what's between Sacramento and Oregon? Half the state's landmass. And what that also means is public health is a challenge when you're dealing with sparse rural populations. And access to both preventive services as well as medical services are scant. So that's why UC Davis has been a leader for the last 25 years in telehealth, which we really so we have unique issues where we're at. We are also a very large university. We've capitalized on relationships with our vet school. We have the best vet school, I would say, in the country. And with our One Health program, and we have one of the best, probably number 1 or 2 in the country. And our One Health moniker is something that really started at UC Davis. And that's also leveraged a lot. And our view of public health is not limited to the United States, but it really is a global view. So that's just a quick review.
Thank you. All right, we're going to move down to Ron. So we know that UCLA trains a very large student body. What do you think it takes for you to ensure students leave feeling confident that they chose the right field?
Well, first, let me begin by thanking Bernadette for just hosting this. Just that we're all together says a lot, because I think in dealing with a lot of the challenges, it's being united and speaking with one voice. So I very much appreciate being here with my colleagues in UC Irvine, the Wen School, hosting this wonderful event. You know, I think all of the challenges that we heard, and it's almost overwhelming, but for public health. But one thing that I am most concerned about is the disinformation and misinformation. Disinformation intentionally spreading incorrect information, and misinformation, just people getting the wrong information. You know, I think about 50% of Gen Zers are getting their information on health from TikTok. So we've got to do a lot better than that. And if you go back to the misinformation, whether it's and disinformation with vaccines and with autism, all of the misinformation and disinformation we've had with COVID. But, you know, history teaches us a little bit. And history teaches us, if we go back to the 1950s, the evidence was accumulating about cigarette smoking, and it's linked with lung cancer. But that was pushed back a lot by the tobacco industry. And there was all of this advertising to squash that information. Remember the Marlboro over there, and all of this thing. And it did take us really way till the 1980s. We had to keep pushing and pushing and getting the data out there. And before Congress took action, before cigarettes went off of television advertising, and we've seen tremendous drops in smoking. So I just want to say that we've been through some of this. I would say this is pretty much unprecedented, but there are lessons from history, and it's to stay the course. Coming back to the question, what do we do? What is UCLA doing in terms of training? And how do we make our students resilient? I think there are two critical things. One is the importance of data and the importance of evidence. And science leads public health. And once you have the science, it's not enough. You have to be able to communicate that science in basic, simple language that people understand. Because at the end of the day, if you lose trust, you lose everything. So you have to go out and meet the people where they are, talk languages in a language that they understand. And we're trying to do that at UCLA. We're trying to improve communication skills. We're trying to improve data skills. We're trying to improve teamwork, get people to work together. And I think most importantly, we have a program about dialogue across differences. We have to not be siloed in public health. We have to have people talking from being able to talk to all ends of the political spectrum. Because if we get siloed, then we don't have those conversations which are so important to change minds.
Thank you. Very good words of advice for everyone. All right, moving to Cheryl Anderson from UC San Diego. So we know that UC San Diego is deeply embedded in border health and global health partnerships. How are those realities influencing the skills and competencies you prioritize for your students?
So thank you, Deena, and I'm sure like our other panelists, I'm just tickled to be here with you this afternoon. What a great turnout. Thank you for hosting us and for showing up to engage in what I think is one of the biggest threats to public health and health in communities today, which is keeping our citizenry engaged. So community engagement, I think, is a really big challenge and a really important step for us to get through a lot of the challenges that we're facing and to advance a lot of the really important discoveries that we have at a tipping point right now. So I want to first say that when we started our School of Public Health just over 6 years ago, it was in the middle of the COVID-19 pandemic, and it was very clear to me that the basic concept that I would teach in my first day of Public Health 101, which was when things are going well, no one notices public health. But as soon as there's a problem, we're at the forefront, right? And so we have a challenge of keeping the compassionate and humble actions that we take every single day to make the world's population safe and healthy being known to people. So right now, in addition to thinking about the federal landscape where we have a revenue challenge, you heard the provost mention a real brand challenge around what's the value of higher education and public health. We also have that constant threat of making the invisible visible. So what does that mean? It means that can we all speak with a united voice around the fact that public health is why we have clean air, why most of us can eat foods that we don't worry will make us sick when we go out and purchase them, why we have clean water when we turn on the tap, why we're able to exercise safely and walk through the streets safely. These are all public health actions that I don't think your everyday citizen attributes the value of having those things in our world to public health. And so really putting a narrative forward to ensure that the invisible things that we all hold dear are made visible to people as the result of public health. That said, how does it take form in the training that we do at UC San Diego? Well, number one is we've intentionally put together a mindset in the way that we teach and learn to do the reverse commute. So every single campus that is represented here, maybe I'll say Riverside is probably the least guilty. We have a town gown issue, right? In Riverside, I feel like town is gown and gown is town, right? But for the rest of us, we sit in La Jolla at UC San Diego, and there are clear differences in life experiences in La Jolla than in other parts of our beautiful city. And so we are intending to teach individuals who want to do that reverse commute, right? We should not expect it into La Jolla to participate in research studies or programs or things that are going to be beneficial in terms of life experiences. We want to meet people where they are, as Ron said, and that requires that we go in a different direction. And sometimes that now brings us across the border to into Mexico, into Tijuana, into Mexicali, because the challenges shared there are our shared challenges and responsibilities. We're also teaching more so about leadership, how people can engage in leadership actions from their very early career days through the entire stage of their careers. We're teaching about interprofessional activities. How do we rely on our colleagues in nursing, in pharmacy, in medicine, in urban planning? You know, how do we really think about these larger basic needs issues as a way into public health conversations? Additionally, we have a justice framing around what we do. There are many words now that are commonplace in public health that we find on a federal landscape being polarizing. Things where we talk about health equity, where we talk about health disparities, where we talk about ensuring that everyone has the opportunity to a good and long optimized life. We find that that is met with pushback like never before in my career. And so continuing that justice framing so that people understand the why of public health. And then lastly, I would just say a very proud moment for us in the school was the establishment of a PhD program, the very first in the country to our knowledge, in dissemination and implementation sciences as it relates to health services research. So this allows us to hopefully cut down that time that it takes for discovery in the university setting, getting into communities. Right now, it takes on average, how many years? 17. On average, 17 years before what we learn gets out into communities for action and absorption. So we want to change that, and those are just some of the examples of ways that we're thinking about this opportunity as a new school to be more impactful in public health.
Thank you so much for creating such a positive climate at your school and the level of impact you're having on your communities. I'm going to move over to Mark now, to my left, from UC Riverside. So we know that UC Riverside plays a critical role in training a diverse and locally rooted public health workforce. So what challenges do you see students facing, and how is your program addressing them?
Thank you, Deena. How's the volume? All right, great. Well, I'm going to start with the geography lesson too. So Riverside's not far. It took me an hour and 5 minutes, and I didn't hit a single toll road somehow on the way down. But think about the county of Riverside. Think about the county of San Bernardino. Add up the square miles, it's bigger than 10 states spatially, 4.6 million people. So think about providing public health services, not only to Riverside, the city of Riverside, an hour away, but to Blythe, to all of the communities all the way out to the Nevada border and the Arizona border. So also a very challenging situation, not unlike UC Davis. Our county also is over half Latinx, with a large proportion of people speaking Spanish as their primary language, as well as a number of indigenous languages, including Purépecha. Healthcare is strained. So I hear our dean, we're in a school of medicine as well, and our Dean Dees, often talks about the differential in equity. So the standard for California and nationally is 60 primary care providers per 100,000 people. We're at 42. So it's not easy to get care, and especially the farther east you travel, the tougher it is. So there are definitely challenges on a number of health indicators. We lag behind. in terms of environmental quality, both in terms of air quality and the Salton Sea. In case you haven't heard, the Salton Sea is drying up and releasing aerosols into the air, causing an epidemic of asthma. So a lot of challenges. So what are we doing to meet these challenges? Well, we have a fairly new medical school, 11 years old, and we have a brand new public health program. So we just started our second year, just finished the fall quarter of our second year of the program. We tried to do everything we could to design a program that would meet the needs of this very large area, bigger than 10 states, over 4.5 million people. So we have a single concentration right now. Our concentration is community health equity. So we are squarely focused on equity. We call it out. We're something called an interdepartmental program. So while my department, the department that I chair, social medicine, population, and public health, I always have to take a deep breath before I say that. It's a small department, but we actually draw faculty for our program from 5 the colleges at UCR, 5 schools and colleges at UCR, which include engineering, the science college, the social sciences college, and medicine and public policy. So, sometimes you hear this terminology, you have to use, we're trying to solve wicked problems. And in order to solve wicked problems related to ongoing structural disadvantage, social determinants of health, you need interdisciplinarity. So those are some of the things that we're doing to try to really tailor our program to the needs of our area.
Well, thank you very much for tackling those wicked problems. I like that term. All right. Michael Liu from Berkeley. Berkeley has been reimagining what a modern school of public health should deliver. So what's one area where you're pushing boundaries or rethinking traditional models?
Well, first of all, just adding my gratitude to Bernadette and the UC Irvine Joe Public Health for bringing this all together. And I actually did my OB/GYN residency in that UC Irvine Medical Center on City Drive in Orange. I have to say this health campus is a major thanks for having me here. So I represent the oldest school of public health in California. For 85 years, we've been fighting for health equity and social justice for all. I have to say we're going through some pretty dark days in public health right now, because not only are we fighting climate change, pandemic threats, chronic diseases, social inequality, all of which pose existential threats to human health. And now on top of that, we're also fighting the spread of misinformation and disinformation, the deepening political division and polarization in this country and around the world at a time when the country and world need to be coming together to be solving these problems. And then just the disinvestment and dismantling of the public health infrastructure from USAID, CDC, to NIH, to the $1 trillion Medicaid cut. It's going to create huge public health crises around the country in the state. So these are surely some of the worst times in public health. But we promised that this wasn't going to be just a doom and gloom. In many ways, it's the worst of times. That could also be the best of times for public health. Because I do think that with all the scientific advancements, with all the technological innovations, we actually have the opportunities, the possibilities to really reimagine healthcare and public health, and to try to save lives, not one at a time, but a million, a billion at a time. So that's okay. But I have to say that we won't get there by doing more of the same. So getting back to your question about what we're doing differently to push the boundaries. Right? So I believe the purpose of the university
is to solve big problems for society. Right? And being UC, our job is to solve big problems, big health problems for the state of California. A university solve problems for society through the research that we do and the students we educate and the societal change that we're trying to bring about. So on the research side, we're very much focused on transdisciplinary research. So universities are very much organized in verticals. Like in medical schools, you have cardiology and nephrology, and the School of Public Health, you have biostatistics and health policy management and so forth. It's actually really, really hard to tackle these big problems I just mentioned like that. So instead of going deep vertically, how do we push out horizontally? So I'm at the best public school, public university in the country. We got some of the top ranked schools of biology and chemistry, data science, engineering, public health, public policy, law, business, and so forth. How do you harness all of that intellectual firepower across the #1 public university in the world to tackle some of these big problems? So that's kind of what we're trying to do on the research side. On the education side, we've been focused on what I call a change maker curriculum. Right? And that's really because most of our students come into public health because they want to change the world, which actually requires more than just a world-class education in public health. Right? They require a certain set of change maker mindsets and competencies and ethics. So over the last about 5 years, we created about a dozen courses. These are micro courses, 1 unit, half a semester to complement the regular courses that we have. And what are those change maker competencies? You start with the 3 C: critical thinking, communication, collaboration. I'm going to add a 4th C, which is community engagement, community building, right? Especially the ability to go into a community, whether you're in red state, blue state, and bring folks together and talk across their differences, keep their eyes on prize, and get something done for the community. Right? And then you think about strategic thinking and design thinking and systems thinking, talk about leadership and management, policy and advocacy. These are the tools and skills that I want to make sure that every single student who graduates from School of Public Health are actually equipped with to go out and bring about the change that we need to see in the world, and whether these are organizational, systems, community, societal, or global change. And then the last thing I'll say is that historically, university has this twin mission of education and research. But increasingly, educators are talking about a third mission of the university, which I call social impact. So university exists not only for the generation of knowledge for the education student, but for the betterment of our community, society, and the planet. So we have a whole new social impact mission. We have a social impact program. I brought in my first chief social impact officer, community engagement kind of director. We're building kind of this social impact platform at Berkeley Public Health. The idea is to build that bridge between counting down, right? And making sure that we're removing, just aligning the academic incentives in such a way that make it easier for students and faculty to be engaged in their community and providing a platform for community to really access the university. So those are kind of the 3 things that we're doing around research, teaching, and social impact.
Thank you. I appreciate all the work to leverage the expertise across the university because it is vast and yes, could be very impactful. And I also appreciate the social impact mission that we all share. So thank you, Bernadette. All right. Congratulations. You have finished your first full year as a School of Public Health. What has stood out the most for you, either as a challenge or a moment of momentum?
So I will say that having become a school means if you do it, you can do anything. That, I think, first thing. And I was just going to say, I'm going to steal the geography. I queried everyone how long it took to get to UC Irvine. Plane, train, automobile, everybody 1 hour, 5 minutes. Showing that we are extremely the center of California. So I started in 2019. We were a wonderful but smaller program. And so we built our school, as Cheryl, during COVID, during Black Lives Matter, during encampments, during, I don't know, there have been so many things that we did during. And I think one of the things that we all did every single time something came up was we were able to pivot, we were able to be responsive. And those are the really important that our students need to know. And so I think our students have, like all of the students at the schools and programs of public health at the University of California, there's a lot of really important opportunity, health equity, health equity, health equity, commitment to community, translating the really important science behind public health out into community, and then learning, all of us learning, all of us, and being dynamic and being be able to respond right now. I mean, so from a perspective of research grants, right? We're hearing that some money is coming out for us to do research in very specific areas, but we're also hearing that we're going to have to respond to those RFAs in incredibly short periods of time, like 3 weeks to 6 weeks, or normally months to put together a grant. And so I have to say, as hard as it was to build this incredibly great, cohesive school of public health from really strong foundations, I think that the ability to pivot, the ability to be flexible, and the ability to be responsive to our students' needs and put in things like advocacy classes, fluency classes, and negotiation. Our students, we learned the hard way, they don't know how to negotiate. And so we've now taught them to negotiate. I don't know if that was good or bad. No. Always good, always good. And really to always be advocates for public health. And, you know, my vision, we have a very large undergraduate population, almost 1,500 undergraduate students. I think about public health and the vision of public health, and not only for the 1,500 undergraduates, but for the entire undergraduate and even high school. If we could talk about public health, the dynamics, resilience, translation, moving to sense of science. If we could do a public health civics, then one day, when it's very dark out there and we're really despairing, all of those that we trained will come out and they'll vote. And they'll vote, and the lights will go on, and we'll be funded, and we'll be allowed to talk about diversity, and we'll be proud of health equity. And so I think, and I speak for all of, I think the faculty here, that that's really our mission, to turn on every light to defend science so that we all are healthier and happier.
I'm inspired. I'm going out there right now and screaming loud and clearly all the public health advocacy.
Perfect.
All right. Well, I've asked this panel many questions, and now it's your turn. So I want you all to think of those questions, fire away. I think we have a roaming microphone. When you do ask your question, if you could kindly introduce yourself first, you can name, what organization or school you may be from, and then you can fire away with your question. We'll do that for about 20 minutes, and then I do have one more question for this panel.
Thank you. Hello, I'm Roberta Lesor, pardon my voice. And I am emeritus professor at Chapman University. Sorry, I should have brought water. I'm a medical sociologist, and with great concerns about misinformation and about people clinging to misinformation. And I think my question maybe is for Dr. Anderson and Dr. Liu, because I heard you talking about reaching into the community and connecting with people. And I think it's pretty clear lately that people aren't persuaded by getting the correct information when they're really clinging to disinformation. So what are they getting from whether it's online chats or groups or whatever, that keep multiplying that misinformation? And I think what they're probably getting is a feeling of a lot of comfort or care for their own worries or family concerns or what they've experienced. And that somehow we need more than the correct information. And that seems to me a big challenge. And I wonder what you've thought about that, or perhaps some kinds of specifics that you might be thinking about. And anyone can answer, really. Thank you.
Well, that's a brilliant observation and a really important part of the conversation. So, when we think about how do we combat something that is so pervasive and effective at sending people down the wrong path, it can seem daunting, right? And I think it goes back to some pretty core public health principles. So when we think about establishing a momentum or a movement around anything in public health, I think the very first thing that we go to is, have we the precursors necessary for trust? And I think what's being established in these media where people get mis and disinformation is this sense of it's easy if you only do X, Y, or Z. And we all know that these challenges are not easy, and yet we have to bring people in a way that's going to keep them engaged and allow them to want to stay the course. So in the efforts that we're making in San Diego, we are trying very hard to be ever present with things that, there's a saying that my parents used to have, which is, if we can trust you in the small things, we can trust you in the big things. And so it's being present for the really small things as well as the really big things, allowing for trust to develop over time, and then hopefully having people really relate to the things that you say in a way that is going to be different from what they'll listen to on the TikTokers, right? It's not easy and it takes time. So I think we also have to have more immediate strategies, which for us, I think is about asking questions, only listening that is sometimes required to understand why is it that a science-based, evidence-based set of information is being replaced by eminence, because people for whatever reason have decided that they don't want to necessarily do the hard things or with the people who have the data. So, Michael, I'm sure.
I'll just add that public health depends on public trust, and the best way to build trust is by building relationships. So I'm proud to be the dean of a school that is the birthplace of CBPR, community-based participatory research. You can do that and that's the idea that when you do research in the community, you do it with the community and not on the community. Right? And 50 years of CBPR, the one key lesson we learned, like you gotta show up for the community. Right? You just don't show up when you want to collect data or do a survey. You show up at town halls, you show up at birthday parties, you show up at funerals. You gotta be there and be accepted as part of that community. I think that's a hard lesson that we learned from COVID. Right? When your health officers show up for the first time in the community to shut your business down, that's not a formula for building trust. Right? So we gotta show up, and we gotta really be building relationships as part of build trust. I was really hoping that you would talk about the community CPR. I think that's how public health builds trust in the community.
Yeah, so thank you, Michael, for that opening. So one of the things that we've been doing in San Diego is we've asked the community to imagine with us. Let's say, for example, you're sitting in a room such as this and someone experiences cardiac arrest and their heart stops beating. How many of you would know what to do? Okay, call 911 for sure. And then what, right? It's going to take them a minute to get here. Fortunately, we are on a health campus, so it'd be shorter than it would be in some other rooms. But what we've engaged in with our community through asking the question back in 2020, what is it that we can do with you now that the new School of Public Health is here? That was a small thing at the time. There was nothing except COVID, but nothing really that our emergency services group could think of. And then 2 years later, they called and they said, our cardiac arrest rates are going up. We'd like to talk with you about that question that you asked back, 2 years ago. And after an hour together, they concluded that I was as crazy as they'd heard because I suggested that we take on a 1 million person initiative, right? In public health, we don't need to do it one person at a time. We can do it 1 million at a time. And so in our little town of 3 million, by the time we're finished in Q1 of next year, 1 million people will know how to do bystander CPR training in San Diego. We asked for nothing. We showed up, we galvanized the entire town, and we have just been marching toward that 1 million person goal. And it is my hope that when we're finished, right, we'll move on to the next 1 million person goal. Because now they've seen the power and the promise of public health and we're working in partnership with them.
And I would say that once you build that trust, then that trust can be passed on with your institution. And Brad, you did a lot in your community during COVID as well, building that trust.
Yeah, I was, and actually Bernadette knows this because she was on my advisory committee. We ran a project called Healthy Davis Together. In the end, we ended up spending $50 million. We had some great philanthropy to intervene for COVID in the whole community. And it was interesting because one of the things, it's involving the community in a very tangible way, but the community broadly defined. We had business leaders, we had faith leaders. We brought in folks from student groups because Davis is a heavily student town. And everybody sort of was on the same page. And we designed that program as we were developing it. We were building the airplane as we're flying it, essentially, by using that kind of input. And in fact, it just resonated. We also had a communications firm, a commercial firm that we work with. We did branding, and it was amazing. I mean, we were all over the news. When they came into Davis, there's a big billboard there. We had this logo there. And we also employed 270 undergraduate students that were our Aggie public health ambassadors. We are the California Aggies here in the Ag School. And their presence in the community, I was just thinking 5 years ago, the Saturday before Thanksgiving, 5 years ago, the Davis Farmers Market is a very big thing. It's just a fun place to go on Saturday mornings there. We had been using our ambassadors on the main campus to do health education, to pass out PPE. But on that Saturday, we deployed them into the farmers market. And I had 10 students with me. I was there. And it was amazing to see our students, these are undergraduates that hadn't done public health before, actually get the experience of doing health education, working with people in the community. So we built a lot of very goodwill, good trust. And in the end, that project where we did everything, we threw the kitchen book at it. We did free PCR testing. We developed a high throughput platform. We did health education. We had incentives for students to stay home during some of the vacations. We did everything you could possibly imagine. At the end, we did have some evaluations that we probably averted about 4,500 infections that related to about 275 hospitalizations, given our demographic structure in the city, and about 35 deaths. And I can tell you, for those in public health, and I'm a cancer prevention person, if I help somebody now with cancer prevention, 30 years from now, they don't get cancer. That's kind of not rewarding because I'm not going to be around to see them, right? But this was one of those situations where public health was on the cutting edge, affecting people's lives in a very acute way. And it was very satisfying to be a public health person to actually see those kinds of returns.
And I would just, go on.
Yeah, I just want to add at UCLA, with the fires that we had, faculty going out into the community that were affected, doing soil testing. they're testing the air quality, they're looking at safety going back into the housing. And it's those kinds of connections that start to build trust. I really think it all comes back down to trust and how do we cultivate that? We talk about data and evidence, but it also has to come alive for people to understand it through stories. I think we need to do in public health a better job doing storytelling. We need to be out there doing more social media as well and making those connections with across the entire age spectrum. I think one of the things that we started at UCLA and Irvine and Berkeley were way ahead of us in terms of an undergraduate program in public health. But we started in undergraduate, we now have an undergraduate program in public health. And many of those students may not go on to be public health professionals. They may go to so many other things. They may go into business. They may go into law. But wherever they go, that public health literacy, that's a backbone. And that will help build trust. That allows us to all speak a common language. And I think public health literacy is important not only as undergraduate, but also in lower school and secondary school, basic information about public health. And I think that creates a common language, which is when you really build trust.
And I would just add one other strategy. I mean, there are other strategies that we can build on once we have community trust. So one of the things that we're doing here, we actually have public health has rented space out in the community because it is tough to go into the Ivy Tower when we've got, for community. And so we need to go, to Cheryl's point, out into community. But one of the things we're also working on is working within families. And who in the family is the trusted person? And how do we work with them? How do we educate them? How do we meet them, to your point, and others, where they are at? And then move that kind of knowledge and experience together so that they can disseminate that knowledge. And ultimately, the trust is greater.
So I know we probably want to move on, but UCR really prides itself on the community connection. So I want to mention one other strategy that I don't think I've heard. So I think there's a basic challenge for us in public health, academic public health sometimes, which is, we do have the Meredith Minklers of the world and others that are very inspirational and are in it for the long haul. But many public health researchers, their interest in a particular community is episodic for a variety of reasons. And so we need to think about structures to have sustainable structures, I believe, for that connection with communities and for building that trust. And so I think many of my colleagues here may have something like this, but at UCR we have the Center for Healthy Communities, which is the unit which has relationships with many, many different community organizations and groups, shows up to those at events, has a long-term sustained relationship, and really is key to our public education efforts, as well as those really vital translational efforts to translate the science to communities. So I just wanted to mention that as a complementary strategy.
Thank you. It looks like we have another question right here. Familiar face.
Daily Michelle, I'm a faculty member here. What a privilege. Wonderful work in the communities. Public health also has no boundaries. And there is an assault on immigration and the talents of UC to really transform public health all over the world. I'm wondering if you can share what you're doing to encourage international students who want to come here and change the world. Thank you.
Who wants to go?
Just briefly, I'll just say Sacramento happens to have a very large refugee population, one of the largest Afghani populations, Syrian, And we actually do teach refugee health. And interestingly enough, our students, some of them are coming from those communities. Some of them have been there for 10, 15, 20 years now. So we've attracted some of those students. I wouldn't call them international. They're our local students, but they are from other cultures, other places in the globe. And I will say that this has become it was already difficult in the last administrations. It's becoming near impossible right now, and I'm very worried about it.
Thank you for that question. We have some short-term measures in place that have been helpful thus far. When we're seeing visa delays, in our case, we consider ourselves to be a sanctuary campus. Nonetheless, when individuals are 5 miles off campus, there are raids going on, and we're right at the border with Mexico, so we have a particularly high impact on individuals from Mexico. One of the things that we implemented in the fall term, in anticipation of some of the visa delays, is we went back to a strategy that we used during the pandemic around teaching and learning, which was our remote designation. We, once the pandemic finished, had removed those designations from our courses, such that the class had to be delivered in person, and if you did not show up in person, you were not able to get credit for it. However, bringing that back allowed our students, while they were waiting for visas to be processed, to still engage in our classrooms. When it comes to public health, our biostatistics training programs, for example, are really heavily subscribed. There are international collaborations, and many countries from all over the world. And so that's a short-term measure. In the long term, like Brad, I remain very concerned about how we can continue to inspire people to come in this direction. And I think at some point, we will find, Michael and I were talking about this, that Americans are going to be going to other countries for the training, because we will now not be seen as a welcoming or necessarily top-rate level of training that we used to be.
So I'll just add, the other day, we held at UCLA an event for public health alumni, and we brought back from UCLA, we gave out awards to the most distinguished alumni. And about half of the honorees were English. And they each told their story about how they got to UCLA. And in most cases, in fact, I remember one alumna from Guatemala spoke about how he wrote a faculty member a letter. And he never thought it would be returned. And the faculty member actually wrote a long letter, handwritten letter. Please come visit. And he said that changed his life when he got that letter, because it meant, paying attention to me. I'm someone. And actually then they came to UCLA and built an entire career, and then received this big award. And sometimes it's programs, but sometimes it's one by one, right? And you do that outreach, and you make those connections, and you change lives.
I'll add that in Office of the President, we are tracking a lot of these federal proposals, the changes, and doing what we can to advocate to ensure that we true to our mission in terms of providing access to our high quality education at UC. So, and I appreciate also, Della, you are being humble in your question, because you've contributed immensely yourself to making education accessible through all of your online curricula, and you have really had tremendous impact globally. So thank you.
I'm Krista Hollinger, President and CEO of the Planned Parenthood Orange and San Bernardino counties. So many of you here, and I'm also a proud alum of the Fielding School. And I'm so happy to hear you all talk about resilience. I know in my role in our organization, we are focused on, my training in resilience, not only at at UCLA, but also working for the UCI for 20 years before being at Planned Parenthood. So I have a lot of questions, but I'm going to narrow down to this. You know, we are a safety net provider at Planned Parenthood. We've been defunded. Of course, we know all of these Medicaid cuts are coming. We've had such a focus on value-based care and population health over the last 2 years, and I'm so concerned about the erosion of that as we see so many people become uninsured and not have access. So I'm curious what your schools are doing and how you see the role of public health and population health in preparing for that, and what you see as some of the challenges that are coming with that.
I guess I will just start. I think that we need to prepare our students to be resilient and to help others to be resilient. And I think we also want to prepare our students to be innovative. It really seems like there's a shift, and we're going to have to go towards more foundations and working more in partnership with private industry and others that we may not even think about as partners at this moment. I'm not sure when we'll be refunded for all of what I think are important areas in health. And so I think our goal is to really press our students to give them the skills to be able to think, you know, to think so that the paradigm shifts. It's really going to be the only way. And we've created, I think, over the last couple of years, and Marison Ramirez is here. There she is, who is our DEI Vice Dean. We've created continued programs in response to all of the problems that keep emerging in public health so that we can get our students to be resilient. And I just want to say one other thing about resiliency, and I think you guys will probably agree. Resiliency is not just about giving people a set of tools and having them practice those tools. A couple of years ago, we were talking about how to defend, teaching our students, and we did this to some extent in practicum classes, to defend science at the Thanksgiving table, right? Because it's always like, you know, Aunt Maisie doesn't really believe in climate change, and you know that was a good place to practice. So I think practicing and skills are critically important, but I also think taking care of ourselves. And one of the things that we're very proud of here at UCI is sort of this focus on mindfulness, on wellness, on care. Because if we can't take care of ourselves, we can't take care of the millions of people in the community. And so I think being innovative and always taking care of ourselves.
Yeah, I would throw in there too, thinking about the systems that are at place here. So, you know, this isn't the first major initiative that we've seen around women's health and reproductive justice, right? This is about over half of the population being unable to receive preventive and other, you know, types of services that are uniquely built for women. And so when the Dobbs decision happened, and for those of you who became, you know, I was a new dean in 2020, and, you know, Bernadette mentioned, not only was it the pandemic, then we were also having important conversations about Black Lives Matter. And then the Dobbs decision came down. And I thought I was gonna just burst, you know? I mean, I had to ink a letter, and it had to happen that day. I was like so on fire about what was going on, and I was being told I couldn't use the word abortion, and I couldn't say this, and I couldn't say that, and I thought, I'm gonna have to like ask for forgiveness because I'm going to. You cannot attack women's rights and reproductive health in this way. So I think remembering that what's happening right now is a part of and connected to the other things that matter for women and the health of women is going to be key in how we move forward on this.
And that's why I think ultimately we gotta go upstream. Because we keep trying to solve these public health problems with public health programs and public health services and to ameliorate the harms caused by decisions that are made upstream. Ultimately, we've got to make sure that we're training the next generation of public health leaders and change makers that are going to go go to the room and sit at the table where the decisions are made, whether that's the White House or every courthouse, whether it's the boardroom or the halls of Congress. Gotta just kind of make sure that we get to positions of power that's going to truly represent the core values of public health.
And I would just actually add that kudos to the lawyers out there, because boy, oh boy, did we need them, and did they save us in these last 5 or 6 or 7 months. We're always saying terrible things about lawyers. We have some lawyers in the audience. But, you know, so students who want to do advocacy or policy as undergraduates, they need to get into law as one option. And to your point, it's the opposite. Yeah.
Hi, Renat Lee. I'm the CEO and founder of the Harmony.life. It's a health platform for women going through menopause, helping them navigate through it. I also have wear another hat. I sit on the board of Indian Institute of Science Medical School. They are actually building a MD PhD program, and we listed Berkeley, we listed UCSF, many of the UC schools. One of the things that we have found in India especially is that there is a difference between public health in those countries versus here. The public health has been mostly take what is being researched and developed in other countries and take it and distribute it, basically. And that's one of the paradigms we are trying to change over there, actually do an MD PhD research program in a 1,200-bed hospital. When you're starting to build something like that, what are the areas of public health? Because that's not the concept that you think about. You think about different, you think about OBGYN, you think about other functions in the hospital, but not necessarily about public health. What are the top things you have thought about when you started public health in your specific universities that you think will be applicable to other countries, India, for example?
I'm at a medical school, UC Davis, School of Medicine. We just had a colleague of mine who runs the public health program at Manmohan Memorial Institute of Health in Kathmandu, Nepal, over. We have a collaborative agreement with them. I've seen actually some of this, and again, medicine has kind of dominated in many parts of the world. It's not a separate discipline. In fact, I remember meeting Sir Jeffrey Rose many, many years ago when I was a graduate student, and I mentioned I was a PhD student in public health, and he thought, well, that was ridiculous because in England, you have to be a physician. So clearly, it's a little bit different. I think there are some unique training issues that come up when you're dealing with health systems and physicians in particular. I have, I'm jealous of my colleagues that have separate freestanding schools of public health in many respects. In some, I'm actually very happy because I get to train these people. We have a good number that actually do the MD PhD. We have a lot of our undergraduate students go right into our MPH program and they get to medical school at Davis. And I feel, and if some of my colleagues might not want to be training pre-meds, right? But I feel that if they get that imprint of public health, even then, it's going to change the way they practice medicine, the way they think about health. It's going to be very important. So I do think that there's a range of things. And I know you mentioned something about population health. There's a whole other world out there talking about value-based care and everything else. They don't get that. That's little, that's little p population health, right? And we have a director, we have an associate vice chancellor for population health who's doing insurance stuff, okay? And it's not public health. The big P population is what I consider to be public health. But I do think that we can't think about separating these things in an overt way. We don't want to do that. We want to have people trained that are going to be very effective. And if they happen to go into healthcare organizations, it's a phenomenal opportunity for them to practice public health. It's also a way for informing us that are on the non-clinical side what we should be looking at. As I mentioned, in Northern California, in Riverside, Kern County, these other counties, the issue there is access to healthcare. It's preventive services, but it's access to medical services. And that may be the biggest impediment they have to their health. So that's public health also.
I think, in addition to what Brad said, it's a really great opportunity to build it that way. So it turns out in San Diego, our newest PhD program has recently established a partnership with our hospital system. And the idea is that our students get to have the hospital as a laboratory for health services work. Now, on the front end and on the back end of healthcare, we have a big public health challenge. On the front end, we have the challenge of access. And we know that delays in getting healthcare are going to cost us significantly on the backside, right? Because you'll have delayed screening, you'll have delayed intervention, you'll have delayed addressing of some pretty critical health issues. But it turns out, even once people come into the healthcare system, upon release, they are struggling with the social determinants of health, which are usually linked incredibly tightly to public health. The upstream factors, such as, are you able to get the medicine that you might have been prescribed? Do you have a home? Do you have a shelter? Do you have a place to go? If you need to rest and heal and recover, what's the situation with your food, right? How are things going to play out around sleep? And so these are just as critical questions, I think, as the things that happen inside the hospital during the care delivery. So I think there's a really neat opportunity in these parts of India that are hoping to build out public health training. And sign me up, I'll go. We can have these conversations, but can't do everything at once, but you got to start somewhere. And I think that's a great place to start.
Well, sadly, we are coming towards the end of this experience, but it has been wonderful learning from our public health experts. I do have one last closing question, and there's a challenge in there. I need you to answer in one word or one sentence. I'm going to let you have a sentence. All right, here's the question, and I'm not going to pick on anyone. You can just shout out your answer. All right, in a year with real challenges, what is giving you the most hope for the field right now?
Absolutely and unequivocally my students, our students. They are the future, and we are inspired by them. We learn so much from them. And we need to teach them a few skills, a few concepts, a few techniques, but they've got the motivation to be the future leaders in the field, and that gives me great confidence.
So I think you heard about all these challenges, all these problems we're facing right now. And best of times, worst of times, and so on. I think that we have an enormous opportunity right now to change things. I think, and one thing I know, Bernadette and I were part of a panel for the Global Health Consortium a couple of years ago, talking about science communications. I have to say, working with COVID and everything else, I thought that the most fundamental problem we had was health literacy and science literacy. I mean, if you really think you can cut it down there, if you can communicate to people the right thing to do in the way that they understand it, and in their language, 99% of the time they'll do it right. And we're missing that. And that is an opportunity, and that is fixed.
I'll just add that public health is a good profession. It's a noble profession. We're trying to do the right thing. And at the end of the day, what everyone wants is for their family and loved ones to be healthy. And that's what we're trying to do. And absolutely our students, the next generation, but we're doing a good thing. I'm fundamentally an optimist at heart. And public health will outlive this current political cycle. And we will have an impact, and we will make a difference, and we're doing good things. And that's what gives me hope and optimism.
Yeah, I'll just say I have hope because conversations like this are happening. And every single time that we are able to talk in a setting like this with people who are going to spend 90 minutes, around public health, we grow the ability to increase our grassroots efforts and work together to really address some of these big challenges.
Right, one word.
Yeah, one more.
Redwoods.
Redwoods.
Nobody's following instructions. Okay.
All right, so we're in California, we're like blessed with like these like amazing rivers, right? Majestic creatures that soar hundreds of feet into the sky, weighs hundreds of tons, despite having roots that are really, really shallow, only about 6 to 12 feet deep. How do they stand? And by the way, they rarely fall, despite all the weather and fire and everything. What keep them up? Yeah, their roots like reach out to each other, right? And intertwine with each other. So in a way, they hold each other up. And so what gives me hope is the community. Like when Bernadette called, no question, we flew down, we drove up, etc. We all wanted to be here to be supportive. And I think that's what we're seeing around the state, around the country. Public health folks are coming together and figure out how do we go through this time together. I think that collective resilience, that's good. What keep us going.
I am so appreciative of all the clear passion and commitment to making this world better and to training the next generation. Bernadette, I'm going to let you close things out.
In one word, oh my gosh. First I would say, well, one word, all of you. How's that? You all give me hope. Our students we have the largest increase in student enrollment in public health, undergraduate, graduate, unbelievable. These students know that they are just facing insurmountable challenges, and this is the field they want to go into. That's hopeful. Our faculty, at the moment that grants were slashed or terminated or whatever, our faculty said, okay, let's pivot. Let's see what we can do. That's unbelievable. And today, all of us here, and we spent some time together even before this, we're in the best educational system in the world. We are the best. Our faculty is the best. Our students are the best. And you know what? I'm hopeful we're going to solve this problem. Thank you all very much for coming.